Jonathan Squires, as Kelly said. I'm one of the movement disorder neurologists out at UBC. And this is the first of, I think, a 4-part webinar series of an introduction to Parkinson's disease that's intended for people who have been recently diagnosed with Parkinson's disease. We know that this is kind of an overwhelming thing that can happen, and we want to sort of give you a bit of a foundation of what is Parkinson's, how is it diagnosed, how is it treated, and things that you can do to live well with Parkinson's disease. So I am going to, this is the outline of the overall webinar series. So I'm actually going to be taking care of the first 4 points here, which sounds like I'm doing the bulk of the work, but it's actually not. So we're going to talk about what Parkinson's disease is, what we know about what causes it, how common it is, how we diagnose it, and some common symptoms that people can have. Next week, you're going to hear from my colleague, Dr. McKenzie, about how we treat Parkinson's disease. And then later on, from the rest of the allied health team in our clinic about tips to live well with Parkinson's disease, things you can do to make the journey a little less rocky. Okay, so we've known about Parkinson's disease for over 200 years now. So this is Dr. Parkinson, who first described it back in 1817, a couple of patients that he saw in London, as well as observing a few people just wandering through the streets with symptoms. So what is Parkinson's disease? Parkinson's is a neurodegenerative disease, which is a broad category of diseases in which certain types of brain cell are slowly dying away. So other examples of neurodegenerative diseases would include Alzheimer's disease, ALS, Huntington disease, that sort of thing. So Parkinson's disease, one of the main problems that we talk a lot about is that the brain cells that produce a chemical called dopamine are slowly dying away for reasons that we don't understand. And in those cells, these proteins accumulate that are called Lewy bodies that we see under the microscope. And those are really the hallmark of Parkinson's disease. The Lewy bodies are made up of fragments of another protein called alpha-synuclein, which is a normal protein that occurs in brain cells. We don't fully understand what it does, even today, but it gets broken down into abnormal fragments, and we believe that these fragments are toxic to the cell. And then the cell kind of gathers them up and packages them into these bigger structures called Lewy bodies, and we think that that might be the cell's mechanism to try to get rid of these things, get them so that they stop doing damage. Okay. So what is dopamine? Dopamine is a chemical messenger, so brain cells use these chemicals to talk to each other, send messages. And in the brain, dopamine has a number of very important roles. So for one thing is it controls movement. It also is important for mood and has other functions. So dopamine, you may be familiar with it in the context of the brain's reward pathway. So when you do something nice that makes you happy, your brain will release this flood of dopamine and it gives us a nice feeling. It also, in certain circuits of the brain, has a role in developing addiction, for example. Dopamine is not the only problem in Parkinson's disease. There's other chemical messengers and other brain networks that are affected as well. But we've historically tended to focus a lot on dopamine, and that's where a lot of our treatments act as well. So what causes Parkinson's disease? Well, the truth is we don't really know still in 2024. We do know that a subset of people with Parkinson's have a genetic cause. There are well over 30 genes now that cause or significantly increase the risk of getting Parkinson's disease. Most people who have a genetic cause have a family history, but not everybody. And often people with very young onset Parkinson's disease are more likely to have a genetic cause. So the younger you are, someone in their 20s, for example, who starts having Parkinson's disease almost certainly has a genetic mutation. But even older people in their 60s, 70s, and older can have a gene mutation. But it's not that common. It's a minority of cases. We don't really know what causes it, but we have well-established risk factors. So the biggest risk factor is age. So the older you get, the more likely you are to have to develop Parkinson's disease. For example, Parkinson's affects about 0.3% of the entire population, but it affects 1% of people over the age of 65 and about 3% of people over the age of 80. Men, for some reason, are more likely to get Parkinson's than women. It's about a 70-30 or 2/3, 1/3 split. People who've had recurrent head injuries, so think soccer players, hockey players, boxers, that sort of thing, are more likely to get Parkinson's disease than others. For some reason, people who live in the countryside are actually at higher risk of getting Parkinson's than people who live in the city. And this may reflect certain environmental exposures, heavy metals in the groundwater, for example, potentially pesticides or other chemicals in the environment. And family history. So having an affected family member, especially what we call first-degree relatives, so that's a parent, sibling, or child, gives you approximately a 2 to 3 times risk of getting Parkinson's disease. And that likely reflects that there are some genetic risk factors that we haven't fully figured out yet. There are a number of other risk factors, but these are some of the bigger ones. And as with many things, we kind of think that there's probably some kind of genetic predisposition. And if you add the right environmental factor at the right time, or the wrong time, perhaps, that might contribute to developing this condition. And probably there are things we don't know about contributing as well. And it's entirely possible that Parkinson's is caused by different things for different people, which is one of the reasons that it's been a bit challenging to hammer out. So how common is Parkinson's? So Parkinson's is the second most common neurodegenerative disease after Alzheimer's disease. About most recent data we have is a few years old, but the estimate is that over 15,000 people are living with Parkinson's in BC and over 100,000 people in Canada. And unfortunately, we expect this number to approximately double within the next 10 to 15 years. Some of that is down to the aging of the population, but the prevalence, how many people are living with it, does seem to be increasing faster than we would expect just from age alone, unfortunately. Lots of work to do still. So how is it diagnosed in 2024? So the first, Parkinson's remains a clinical diagnosis. We'll come to this, but we still don't have a good test. So clinical diagnosis means that we diagnose it based on the story that we hear from you about the symptoms that you're having, and then things that we find on the physical exam. And so the first step that we do is to establish whether someone has Parkinsonism. Now, you might have heard Parkinson's versus Parkinsonism, and what the heck is the difference between them? Well, Parkinsonism is a description of a group of symptoms that include slowness of movement or bradykinesia. That is the symptom that you must have in order to have Parkinson's disease. So bradykinesia is really the defining feature of Parkinsonism. The other features are increased muscle tone or rigidity. So if you're in the doctor's office and we're moving your arms and legs around like this, that's what we're checking for. We're looking for resistance to passive muscle movement, not necessarily that stiff feeling that you might get sometimes. And then a resting tremor. So resting tremor means that it happens mostly when your affected body part, your arm, your leg, whatever, is completely at rest. So you're resting it on an armrest, sitting quietly, then it starts to shake. That's the type of tremor that we typically see with Parkinson's, though not universally. So in order to have Parkinsonism, you need slowness of movement and one of the other two. So once we establish you have Parkinsonism, we have to see what's causing it. And Parkinson's disease is the most common cause of Parkinsonism, but there are other causes as well. And we mostly look for features that make us worry that you don't have Parkinson's disease. And if we don't see any of those, then we conclude, well, Parkinson's is the most likely thing. So as I said, there is no test at present. The only way we have to confirm the diagnosis of Parkinson's disease still in 2024 is to do an autopsy, which is not a good option, and I have not yet sold anybody on it. Typically, MRI and CT scans are normal, or they might show some just what we call atrophy or shrinking of the brain that are non-specific. And then we do have some fancier functional imaging scans like PET scans, STAT scans, which is a nuclear medicine scan that can provide supportive evidence, but not definitive. There is, however, now a test that's almost ready that is pretty good at diagnosing Parkinson's disease, which is called an alpha-synuclein seed assay. So far, the best results for that actually come from spinal fluid. So people need to have a spinal tap and have the test done, but they're also looking at whether they can do it in blood and maybe skin biopsy as well. So stay tuned, that one will be coming. But for now, we don't have an available test. So I mentioned that there's a list of other things that can cause Parkinsonism. So if it's not Parkinson's disease, the things that we think about are another group of neurodegenerative disorders. You might hear those called Parkinson's plus syndromes or atypical Parkinsonisms. Those can start off looking exactly like Parkinson's disease, but they have other features that come up that you don't expect to see in someone with Parkinson's disease. And we call those red flag features. So when you see a doctor, we're always on the lookout. Is there anything here that I don't expect that makes me worried about one of these other conditions? The mimics of Parkinson's actually tend to be more severe than Parkinson's, progress more quickly, and unfortunately, we don't have good symptomatic treatments. So we don't want you to have one of those things. Certain medications can cause Parkinsonism. This is mostly a class of medication called neuroleptics, so mostly antipsychotic medications that people might be taking for schizophrenia, bipolar disorder, but they do sometimes get prescribed for other reasons as well. So we look at the medication history. One or two nausea medicines and a few other scattered things here and there can cause Parkinsonism as well. Usually, if we think it's related to a medication, the symptoms will go away if you stop the medication after a while. And then rarely, people can have some kind of structural lesion of the brain. So if you have a tiny stroke or a tumor in just the right spot in your brain, it could cause similar symptoms. And that's one of the reasons that we scan most people with Parkinson's, just to make sure that there's not there. Although admittedly, usually if there's a lesion, there are other symptoms that make us worried that something different is going on. Okay, so how good are we at making the diagnosis in the lack of a test? The answer is not very good, to be really honest. So we only get it right about 70 to 80% of the time in the first few years. Most of the misdiagnosis is because of those other neurodegenerative disorders, the Parkinson plus syndromes. Those can look completely identical to Parkinson's disease for the first few years, and the best neurologist in the world wouldn't be able to accurately tell them apart. And that's why we always keep an open mind. As the disease progresses, it becomes more clear what's going on. The Mayo Clinic years ago did a study where they started with people who had donated their brains and they had autopsy with, so they knew what they had, and then they looked back in people's charts to find out what they thought they had at the beginning, and that's where those numbers come from. And it turns out that even when the people had died, they still had the diagnosis wrong, maybe 5 to 10% of the time. And most of those people had a related disease called progressive supranuclear palsy, which is one of the Parkinson plus syndromes that can closely mimic Parkinson's disease. And like I said, usually when you see a neurologist, there's always that little voice in the back of our head saying, is there anything atypical here? Are we missing something? Or is this Parkinson's disease? So we try to keep an open mind. Usually after 5 years or so, it's pretty clear whether it's going on. Okay. Another common thing that people worry about is how will my condition progress? We know, unfortunately, Parkinson's disease is a progressive condition, and it will worsen over time. But the question is always how fast, what will happen. In general, the progression is very slow over years, but it's very variable between individuals. And some people progress relatively quickly and have significant disability within 4 or 5 years. And then other people progress very, very slowly. I mean, I have patients who've, after 15 years of Parkinson's, were still skiing double black diamond trails. So the rate of progression is very highly individual, but still over years and not months or weeks. In general, women with Parkinson's tend to have slower progression. And in general, younger people tend to progress more slowly. So on the one hand, you have Parkinson's when you're younger, which is not fun, but it doesn't progress as quickly on average as people with older onset. One important thing to keep in mind is that if you wake up one day and suddenly feel like your disease has progressed by 5 years overnight, that's not your Parkinson's disease. That's usually a sign that there's some other problem going on. So commonly an infection, like a bladder infection, pneumonia even. Sometimes people with Parkinson's, the only symptom they may have of an infection is that their Parkinson's is worse. Or any other medical problem that's happening could also make things worse. So when people call us and say, hey, doc, my symptoms, I feel way worse, we usually send them to their family doctor for a workup first to make sure there's not some other medical problem contributing to that. And then if you treat whatever the problem is, generally speaking, things will go back to how they were. It doesn't sort of progress and stay that way. Okay. So we've talked about what Parkinson's is, what we know about what causes it, and how we diagnose it. But what symptoms do people have? What kinds of things might people expect? I will say, if you read about Parkinson's disease, the list of symptoms can be daunting. It can cause many different things. I will say nobody gets all of them. one of the challenges is that nobody can really predict which one you might get. And so we generally, when you go to the doctor, we ask you all kinds of questions about things. And it's just kind of trying to figure out what is going on and what's bothering you. But you may not get any of these things that you read about. So try not to worry too much. In Parkinson's disease, we break things down between premotor, motor, and non-motor symptoms. So we're going to go through those in turn. So the premotor symptoms are those things that come up before the tremor starts, before the movements slow down. And it can be tricky to link them with Parkinson's until later on. And these things can happen 15 to 20 years before other symptoms start. And they can include things like losing your sense of smell or reduction in sense of smell. Constipation can happen 15 years or more before anything else happens. In fact, if you're a man around my age and you're early to mid 40s and you have constipation, that is a risk factor for getting Parkinson's disease, because really it might mean you already have Parkinson's disease. It just started in your gut and it's making things dysfunctional. There's a condition called REM sleep behavior disorder, where people start to act out their dreams. Dreams become really vivid and lifelike, like you're watching a movie. People might start to scream, kick, punch, thrash, and can be quite violent. And people throw themselves out of bed, and they might even strike their bed partner inadvertently. And that too can happen a very long time before anything else happens. And then finally, people can develop depression and anxiety when they've never had problems with that before in their lives. And that can be an early sign of Parkinson's as well. So moving on to the motor symptoms. So one common question is, I don't have a tremor. Can I still have Parkinson's disease? Well, yes, you can, in fact. In fact, 20 to 30% of people with Parkinson's never have a tremor. Like I said, the defining feature of Parkinson's disease is really the bradykinesia, the slowness of movement. So bradykinesia can manifest in a lot of different ways. So movements slow down. So people will walk more slowly. They might take smaller steps. You might drag one foot on the floor. So shuffling gait can be a manifestation of bradykinesia. So people often note that their face is less animated. We talk about the Parkinson's mask. Families will often wonder if the person is depressed because they just don't have much facial expression, but it's just slowness of the movements of the face. Your handwriting can get smaller and slower. People often don't swing one of their arms as much when they walk. And Parkinson's is an asymmetrical disease as well. So one side is always more affected than the other. Generally with the bradykinesia, things take longer to do. It's harder to keep repetitive movements going. So people will often say, well, I'm trying to, beat eggs and I just can't keep that movement going, or I'm trying to wash my hair and one arm just doesn't want to keep going. So those are manifestations of bradykinesia. Rigidity, like I said, is something that we note when we're moving your limbs passively, and it may feel a little uncomfortable or stiff. And I think the combination of the rigidity and the bradykinesia together, people's brains will often interpret that as a feeling of weakness, because you have to work harder to do things than you should. And so the brain interprets that as being weak, even though when we test your strength, there's nothing wrong with it. And then postural instability is an important late finding in Parkinson's disease. So as humans, we have reflexes in place to prevent us from falling down. If you have stumbled in the past, you'll do something, you'll reach out, you'll step back to catch your balance. With Parkinson's, as things progress, people develop problems with that reflex. And so falls become more of an issue later on, although that's not something that should be prominent early on. And if you're falling all over the place, if people are falling once a week or something in the first couple of years, then that's one of those red flags that we talk about. And we start thinking, is there something else going on? And then the non-motor symptoms. Now, we spent a long time ignoring the non-motor symptoms largely in the medical community up until maybe the last 15, 20 years or so. And the picture of the iceberg is fairly apt here. So the visible part of the iceberg is the motor stuff. So everybody can see that you've got a tremor and that you're slowing down. But these other symptoms that come up below the surface tend to be invisible. And when you ask people with Parkinson's disease what really affects their quality of life, these are the symptoms that people mostly talk about. So they're very important. So we'll walk through those. And again, nobody gets all of these things. Nobody's that unlucky. So it's a bit variable. So mood symptoms are very common. So depending on what study you look at, the estimates vary quite wildly from 50 up to close to 100% of people will develop depression and anxiety. And you may say, well, of course I'm depressed, I have Parkinson's disease. But they've actually done work where they've compared people with Parkinson's disease to other medical conditions that are equally disabling, like bad rheumatoid arthritis in the past before you had treatment for that. And people with Parkinson's were more likely to be depressed than people with equally disabling conditions otherwise. So we know that depression and anxiety are symptoms of the disease itself, and not just your body's reaction or your mind's reaction to having this not that pleasant disease. It's often overlooked and underreported, so we try to actively ask people about it. It can respond well to treatment, same treatments that are used for any other person with mood symptoms, and medications can help. And again, Dr. McKenzie next week is going to talk in more detail about treatments for these things. Other psychiatric symptoms are common. So apathy can be a real bothersome symptom. It's usually a later sign, so you don't expect significant apathy up front. So this is people just not motivated to do anything. They just want to sit and watch television. They don't want to see their friends. They don't want to see their family. All they want to do is just sit there. We tend to associate this in most people with depression, but in neurological disease, people can have apathy despite completely normal mood. This is usually more problematic for people's families. The apathetic person doesn't generally care too much about their apathy, but it can be a problem that is kind of difficult to treat, unfortunately. Hallucinations are another thing that can happen, but again, usually later. If you see early hallucinations, that can be a sign that something else is going on. In people with Parkinson's, they're usually visual, often children, people, insects, that sort of thing. People will commonly have this sense of presence, so they feel like there's somebody right here behind them when there's nobody there. They may see things flitting by in their peripheral vision. But formed visual hallucinations shouldn't happen in the first couple of years. Sleep disturbance is very common. Almost everybody with Parkinson's has some kind of problem with their sleep at some point. And there's many different ways that Parkinson's can mess with your sleep. For one thing, we all have this circadian rhythm you may have heard of, so the body clock. So we're supposed to get tired at certain times of the day, early afternoon, and then bedtime. The body normally releases surges of hormones that make us sleepy so that we'll sleep. This cycle gets a bit dysregulated in Parkinson's. And people often find that early afternoon wall hits them like a freight train, and then they may have trouble sleeping at night because of it. People with Parkinson's are more likely to have restless leg syndrome. The reverse is not true if any caregivers out there struggling with restless legs. And obstructive sleep apnea, much more common in people with Parkinson's than not. And usually we associate sleep apnea with people who are maybe a bit overweight, or they have kind of a short neck, that sort of thing. But people with Parkinson's, even without any what we consider risk factors for sleep apnea, can have that condition. So it's not a bad idea to ask your family doctor to screen you for that as well if you're having a lot of trouble with daytime sleepiness and sleep disruption. Sometimes people, their tremor will come back when they're asleep, or their medications wear off and they get very stiff and uncomfortable, and that will wake them up from sleep. Leg cramps are common, often reflect wearing off of the medication. Fatigue actually can be a primary symptom of Parkinson's disease, even if you're sleeping well and everything else is going great. People complain of a lot of fatigue. And then I mentioned that REM sleep behavior disorder before, where you're kind of thrashing and screaming and acting out your dreams. Well, that can wake you up, and that can affect the quality of your sleep as well. And then there are probably more factors than that. A lot of people complain of rumination over things, which is the most common cause of insomnia. Unfortunately, having Parkinson's doesn't protect you from any of that stuff either. Lots of things. Now, autonomic dysfunction is another class of things we talk about. So the autonomic nervous system is the part of the nervous system that controls what we call the housekeeping functions of the body. So this regulates your digestion of your food, bladder, bowel, blood pressure, heart rate, breathing rate, that sort of thing. So that part of the nervous system is involved as well. Constipation is very common in Parkinson's, like up to 70% of people will have constipation. The bowel just doesn't contract normally, it slows right down. The stomach may not empty properly, so people can complain of feeling bloated after they eat or getting full really quickly. And as I mentioned before, constipation quite commonly might be the very first symptom people get, and might be 20 years before the trauma starts, for example. Bladder dysfunction is, again, extremely common. Usually with Parkinson's, it's frequency, so you go more often, and then urgency. You gotta go right now. Obviously, as men get older, there can be prostate issues as well that can contribute to the bladder. Usually something like that is more like you got to go often, but when you go, it takes a minute to get the stream started, and then it's kind of dribbles, and then you can't quite empty your bladder, and then you finish, and then 5 seconds later you got to pee again. So kind of different symptoms than what we expect for Parkinson's disease, which is really more the bladder is kind of like irritable and hyperactive. So that can be a problem as well. Blood pressure regulation can be a bit affected as well. So any of us can get that thing where if you stand up really quickly, you get a bit of a head rush, especially if you're a bit dehydrated. Parkinson's kind of makes that worse. And then unfortunately, most of the medicine that we use to treat the symptoms of Parkinson's disease falls in the blood pressure worse. Again, this shouldn't be a prominent symptom early, but can become problematic later on. People have cold hands and feet. I hear people complain about that all the time. That's not dangerous. You're not going to lose circulation to your limbs or anything. It's a nuisance for sure, but it's not dangerous. Just doing things to warm the limb, warm blankets, that sort of thing, are the best thing there. Sexual dysfunction is very common in both men and women. So erectile dysfunction is a big thing in men. Lots of things can affect sexual health, self-esteem around having the Parkinson's disease, just difficulty because of mobility challenges. But there is help available for sexual dysfunction as well. Both medical and the sexual health clinic here in Vancouver, for example, is a good resource for people. And then some other things. So pain is very common. There's different types of pain that people with Parkinson's get. One is musculoskeletal pain. So I mentioned before, Parkinson's is an asymmetrical disease. So one side is affected more than the other side. So your biomechanics are a bit off. You're struggling to bring the more affected side along. And so people are more likely to get things like tendonitis or bursitis, things like that. Those you treat just like you would for anybody else who has that condition. Usually we send people to their family doctors for that, because as neurologists, we're not very good at managing musculoskeletal problems. People with Parkinson's also get central pain, so from the brain itself, not from anything in the body. And that can manifest as a tight feeling, pressure. People get pins and needles, this like band around their chest kind of thing. It's very unusual. We don't really fully understand why that happens. Generally speaking, well, always actually, that central pain is a dopamine responsive symptom. So it tends to come when medications wear off and then reliably goes away when you take the next dose of medication. So if you have pain that fits that pattern, that's from the Parkinson's disease. Pain that's just kind of always there, or when you walk, that's going to be more musculoskeletal. So a little bit, and they require different treatment, essentially. Cognitive changes will eventually occur in the majority of people. I think this is the thing that people fear the most about Parkinson's disease. The best data that we have is from Norway, where after 20 years of Parkinson's disease, about 80% of people will have some degree of dementia. The best things you can do to prevent that, as our team will talk about, are to exercise regularly, control risk factors for heart disease and stroke, blood pressure, diabetes, quit smoking, that sort of thing. Stay socially active, and stay mentally active. So keep using your brain, learn new things at any age. And that is all that I have, actually. We've got lots of time for questions. These are my dogs who keep me active. And next week, you're going to hear from my colleague, Dr. Mackenzie, who's going to talk to you all about the treatment for Parkinson's disease. So I've tried to give you a little bit of an overview of what Parkinson's is, how we diagnose it, which is probably the less interesting thing for many of you. But if there's any questions pertaining to that, feel free to pop them in the chat, and I will do my best to answer them for you.